Hello friends, this is Dr. Shanta Kumari, President Foxy and Treasurer FIGO. In this episode, we bring to you another sparkling diamond which India has produced in the field of OB-GYN, Dr. B.N. Purandare. Dr. Balachandran Neelkant Purandare, whose contribution to the gynecological surgeries is recognized throughout the world. He was a skilled vaginal surgeon, and his series of vaginal hysterectomies and vaginal sterilization operations of more than 25,000 is a unique achievement. Friends, you agree with me that vaginal surgery is the art and skill which every gynecologist should possess. In fact, Dr. B.N. Purandare had many occasions to demonstrate his skills and original surgical techniques in several countries in the world, like his technique of abdominal cervicopexy for the nulliparous prolapse, vaginal sterilizations, and recanalization of the tubes. Let's know about this legend a bit more in this episode, and I'm sure that will inspire all the young gynecologists of my country to learn the art and skill of vaginal surgeries, which every one of us should have.
Hello friends, in this episode of Diamonds Are Forever, we talk about the founder fellow of the Indian College of Obstetrics and Gynecology. ICOG is just one of the things which he has started. He has contributed immensely to the field of OBGYN, be his innovative surgeries or his affiliations to various national and international bodies. Dr. B.N. Purandare was born into a family of physicians in Mumbai on October 27, 1911. He graduated from the St. G.S. Medical College in 1934, securing a number of merit scholarships during his college career. He did postgraduate studies in KEM Hospital, and after finishing his MD in 1937, he went abroad to Edinburgh and London, during which time he had a unique opportunity to display his skills as a vaginal surgeon, which left all impressed. In fact, in his own words, in an interview given to Prasar Bharati All India Radio, he said he describes an instance when, while demonstrating a vaginal hysterectomy in Cologne, Germany, when the surgeon praised his hands, he described why Indians have great dexterity in their fingers.
When I was demonstrating an operation of a vaginal hysterectomy, that is removal of the uterus from below without opening the tummy in Cologne, after my operation was over, because I just do it without putting clamps. That is my technique of not to put clamps, but by sutures. See, you do the whole operation. And the professor there, he was watching the thing. In the end, he said, I got one desire. I thought he was asking for another major surgery of a complicated type or something. You see, no, the point is like, I want to feel your fingers. I want to feel you. I said, what is there in the fingers? No, I was watching you for the last 10 minutes. The way dexterously you removed the uterus and the fingers were all working dexterously. Your hand and shoulders, and there are no movements at all. This is something different from our German surgery. I said, what is it? He said, no, the fingers have been working, and that's why I was very keen to feel that. And what is the secret? How to become dexterous in the fingers? I said, do you believe in your rebirth? Oh, no German will believe in the rebirth and all. That's all for India. I said, no. That's for India. That is characteristic of India. But one thing is there. If you believe in the rebirth, you would have been born in India and you would have developed this dexterity of the fingers and things like that. What is the secret? Why you Indians have got this characteristic? I said, it's not only for Indians, but it's the people from Orient. Chinese and Japanese also, they use their finger very nicely like us. But one thing is there, fact is that right from our birth, when we start eating with our fingers. And there's this association between the fingertips and the brain so well established that I think the movements of these fingers, our delicate fingers, are there. So you'll find it's not only dexterous in the surgical thing, but various types of fine arts that are there prevalent in India. You have nice embroidery and other things that are carried out by various professions. They're always very brilliant in their use of the fingers.
After securing his fellowship in 1939, He worked in the KEM hospital, and in 1957, he became the head of the Department of Obstetrics and Gynecology and Dean of the Navrozji Vadia Maternity Hospital. He set up the Dr. N.A. Purandare Research Center in memory of his father. He was the Dean of the Medical Faculty of Bombay University and President of the College of Physicians and Surgeons of Bombay. He was also the Honorary Advisor on Family Planning and Maternal and Child Health to the Department of Health, Government of Maharashtra, and Technical Advisor on Family Planning to the Union Government. He was a member of the Shantilal Shah Committee for Legalization of Abortion. This was a very important change which has happened in India, legalizing abortion. And we have in his own words, when he described the struggle they went through to bring this act of medical termination into the country.
That a bill was first brought in as an abortion bill, when it was prepared. For 1 year, we were going around all over the country and we interviewing the doctors and lawyers and other people just to find out whether there's a need for such a condition. And ultimately, when it was put before the parliament, it was thrown away because abortion bill is something which should not be. But later on, I suggested that we'll change the name of abortion bill. We'll call it as Medical Termination of Pregnancy Bill. And immediately next year it was passed because it was a medical termination of pregnancy.
For his outstanding work in family planning, he was honored in 1972 with Padma Bhushan by the Government of India by the hands of then President Shri V.V. Giri. In fact, he was the first one to suggest postpartum sterilization. And one can hear from the same interview in his own words how he first suggested it in Lahore. You wouldn't believe this, after a woman has had 10 children. Listen to this.
Dr. Purandare, you worked as an advisor to the Government of Maharashtra and Government of India on MCH and family planning. So how did you develop this program?
See, my interest in this family planning program started in 1939. I was the first man to start doing a postpartum, that is after delivery, operation for sterilizing the patient. Now, then that time, after I did about 30 cases, I presented the material to the All India Congress of Obstetrics and Gynecology at Lahore. See? And there, after doing these 30 operations and showing the people that after delivery, this operation is safe and things like this, originally I suggested that it should be done after 10 children.
10 children?
10 children, you see, because that time I proved it, that after the 10th delivery, a mother is nearly 50% chance of her dying in the next deliveries, you see, and all the statistics was taken out. You see, they would die of a rupture of the uterus or some complication coming up and things like this. So, however, these gynecologists then did not like it. They said, look at this young boy coming up and telling that you should do a sterilization, do a biggest sin, you see, of sterilizing a woman like this. But gradually people also realized, government also started taking interest in that. And ultimately it came to 6 deliveries, then it came to 4 deliveries. Now it has come to about do ek or do bacha bas.
He was very keen and inclined to engineering as a subject. When we look at the surgeries which he innovated, like the abdominal cervicopexy, one can understand the use of that knowledge into the medical field.
As it happened, my inclination towards engineering was responsible to give a different turn to my outlook of the medical profession.
Yeah.
See, because I found that lots of new innovations could be ultimately I was able to do because of that attitude to develop something new. And that was the reason why in the case of an operations, I could devise different types of operations.
Amir is practicing in South Bombay and attached to the Somaiya Medical College. He's the second vice president of MOGS, and he was a joint secretary of FOXI in 2019. He is also doing a very important role in the Foxy Manyata project. So welcome, Amit.
Thank you so much, sir, for having me here. It's indeed a very nostalgic and proud moment for me to be speaking about my grandfather. My grandfather, probably when I was about less than a year old. But what we are going to be talking today is about his cervicopexy operation. And I think it is a landmark operation and for especially young women with prolapse. This operation was designed by him in 1956, and its primary indication was for young women with second or third degree cervical prolapse as per Shaw's classification, where childbearing is to be preserved. And the first article came about this prolapse surgery as a sort of a meta-analysis in those days, 10 years after the operation had actually been devised and introduced by him. And this actual article is from our Journal of OBGYN way back in 1966, and you can see the original manuscript. Now, he went on to say very clearly that operative treatment for genital prolapse poses two important problems before the operator. One, that the repair of the prolapse should be by a method which will not jeopardize future childbearing. And two, recurrence of prolapse will not occur following vaginal surgery. These are actual pictures of him performing the surgery. You can see that the uterus is being pulled up, the bladder is being pushed down by the sponge holder, and the rectus strips are being prepared. This is the actual round ligament forceps that he used. You can see his initials BNP on the magnified image. And this forceps was one which he bought in London. This instrument may be, sir, about 70 years old now, or even more than that. And look how fine it is. It's made up of stainless steel. So there you can actually see the instrument here being used by him. And these are the two strips which are being overlapped on the anterior part of the cervix. You can see the bladder flap is being closed and the surgery is being completed. Now I move on to the actual analysis. This particular trial is almost 60 years old now, and in 191 cases at the KM hospital of nulliparous prolapse, they compared between the Fothergill's operation and the cervicopexy operation. So there were 81 cases of cervicopexy which have been described, and at the end of this study, they clearly came to note that the cervicopexy was an advantageous operation in nulliparous prolapse, and they recommended that it was the operation of choice. The cervical supports were weak, and they believed that they required some additional help to hold up the cervix, and therefore this operation was the operation of choice. That time the Fothergill's operation was the commonly performed operation. This operation changed the mindset totally, and we moved on from transvaginal procedure where amputation was done to a suspension procedure where biograft was used to pull up the cervix. So I think this was his visionary innovation, and I think, like you rightly mentioned, he had a technical mind which helped. Now let's look at the physiological results. Out of the 21 patients who were suffering from prolapse in cervicopexy in their initial series, 20 of them were cured. Anatomic results also showed that the cervicopexy operation, 17 out of the 18 were cured completely. Only one patient had a probable recurrence. This particular slide is very important because then fertility was a big issue with respect to prolapse. And the only operation that they did was the Manchester's operation, where they amputated the cervix. And all of us know that it did adversely affect fertility. This is a direct comparison. And you will see in the cervicopexy operation, out of the 25 patients, not a single of them had secondary sterility because of the prolapse, because of the surgery. While in the Manchester operation, out of the 62 patients, they went on to say that about 5 of them had sterility and hence could not conceive in the post-operative period. So this was one of the important things. In 1987, that is about 3 decades later, Dr. V.N. Purandare wrote in the editorial of the journal, he was the journal editor then, and he compared and he sort of analyzed the cervicopexy and the sling operation, that is the Shirodka sling operation for prolapse. And there are two important things that he went on to say. Number one, he went on to say that this operation of cervicopexy is very simple and even novices can carry it out. And therefore, the survey which they carried out over a period of 5 years, they found out that this was the most commonly performed operation for nulliparous prolapse. Another important technical point that was brought out was the concept of the static sling versus dynamic sling. He went on to say that a static sling is one which remains rigid during changes in intra-abdominal pressure. But in cervicopexy, you have the dynamic sling where the sling actually actively pulls the uterus up and anteriorly during straining, and hence it is called as dynamic sling. This is how the pexy looks today. We have the Marcelin tape. So in those patients who have got biologically weak tissues, poor collagen, the tape is now proven or stood the test of time and can be very easily, beneficially, safely used during the pexy operation. Dr. B.N. Purandare was, as all his students tell me, my father tells me, probably one of the master surgeons of the world. He was like someone like Picasso or Van Gogh. You know, he was an artist in his surgery. This was in fact recognized all throughout the world.